first one we've got with 14 votes is comes from Sarah Desmond, who's one of our counselors in Kosovo, and the question reads: just wondering about the overlay of the medical versus the social model. People with disabilities in Australia are wholly dependent on the medical model in order to access support, and due to refugees often not having the necessary medical evidence that defines, verifies, and categorizes the disability, they simply do not get appropriate support. The NDIS is increasingly difficult to access due to this. Here comes a question: does your research address inequity in access? Angela.
Thank you, and what a great question. And I would agree with all of that. So previous research that we've conducted that's involved STARTS and Foundation House and Settlement Services International and the New South Wales Refugee Health Service in particular, we've looked at that very issue of access and issues with access for people with disability and family members from refugee backgrounds. And we actually were involved in co-designing some resources to address that for people. That involved some videos which we created around, particularly around access to the NDIS, because that was a major issue that people identified. And also around how you make a complaint, because while there is some information on the NDIS website in Arabic, there was nothing around the complaints process, which is pretty important for people to know how to do that. We certainly heard from people of issues of not having had diagnosis or having the evidence of diagnosis when they left their country of origin, and how that impacts on them when they do come to Australia and need to provide evidence for joining the NDIS. And the expense here of getting assessments done and waiting periods and all of those sorts of things. And that certainly does create barriers for people. Nonetheless, a lot of the people that we spoke to were accessing the NDIS, and that was often because they had connected with either a family member, somebody in the community, or a service provider who was able to help them navigate the system. And I think that's really important and goes back to that, the issues that I was talking about around, that those bonding and bridging networks and the connection that people have with other people. And so I think that's got to be a real focus within that settlement period in particular for people, is making sure that they know what's available and know how to access and apply for what's available. Yeah, but it's an ongoing issue, absolutely.
Thank you, Angela. The next question is also addressed to you, comes from Rafik Tanius, and reads: people with disabilities are overrepresented at all stages of the criminal justice system. And that's from the Royal Commission into Violence, Abuse, Neglect, and Exploitation of People with Disability. Did any intersections with the criminal justice system present in the research?
Interesting. No, they didn't. Now that's across a number of different projects that we've conducted now over 7 years. So no, we didn't come across anybody who intersected with the criminal justice system at all. I'm sure that there are examples, but not ones that I've heard directly about.
Thank you, Angela. Yes, I thought it was an interesting question. Maybe something that it'd be worthwhile looking in the future. I'll throw another question to you, and then I got a couple that we address to Bonnie. What supports could be explored with when clients with disability are in periods of transition without access to health services due to the visa status?
So do you mean when people have left country of origin and in transit to a resettlement country? Is that
I suspect this question refers to people that are in the type of bridging visas. That mean that they don't have access to basically Medicare.
Yes.
they would be able to access services like studs, but not
Yes.
the whole gamut of services in.
Yes. Okay. So people already in Australia. Yeah. Look, our research only looked at people who had been accepted as refugees. So we didn't talk to people who are what we call asylum seekers, I guess, and on bridging visas, etc. And that was because we knew people just weren't going to have access at that point, and it was a whole other area to be looked at. I think it is really important, but it's not something that we have conducted research around. I guess just anecdotally hearing people discuss this, it is something that we need to draw attention to, and I know the Refugee Council and other organisations have been trying to draw attention to this because people are really left to their own devices, and really around connecting with non-government organisations or local people within communities to really provide that support that they're not getting through the formal system. But it's not adequate. We know that.
No, thank you, Angela, certainly. And maybe if I can, because this has come up, there's actually several people asking this. Do we know what proportion of humanitarian entrants from Syria, Iraq, in particular in relation to your research? But I think a couple of other people have asked in general in terms of refugee program, come to Australia with a disability.
Yeah. So we don't have accurate records, which is not good. But we do know that I think it was between 2015 and 16. So the health waiver came in 2012, which meant for the first time people with disability were accepted as refugees into Australia, because the officials no longer had to assess what it would cost to support the person when they were here. So that came in 2012. The figures that I've seen were from 2015 to 16, which indicated that 1.4% of the people who had come in on humanitarian visas came under that health waiver. Now, we don't know exactly what that means. We don't know what proportion of those people have what we would call disability, and what proportion might have chronic health conditions but not disability resulting from that. So we just haven't got the breakdown in terms of the data to know exactly. I did a bit of a back of the envelope calculation based on that 1.4%, and estimated that it would have been around 600 people from Syria and Iraqi backgrounds who came in under that health waiver, who we potentially could think were people with disability.
No, thank you, Angela. And again, something else that probably there's both a need for further research, but also some advocacy in terms of how we keep, some of this data that is important to a question to you, Bonnie. Had some of the participants in the CHIME project been affected by female genital mutilation or rape by ISIS or other terrorists? And did they benefit from the project?
Thank you. So no, participants did not disclose that experience, although the issue of female genital mutilation or genital cutting did come up in our discussions, particularly in relation to the problem of a lack of culturally appropriate care. So healthcare providers not being experienced in facilitating natural births with people who had experienced genital mutilation, because women who had given birth in their home country without a problem felt they were pressured to have a cesarean section just because the healthcare provider didn't understand their body and what was needed in order to support them to have a natural birth. So that was discussed a lot, actually, in the context of culture and just the disconnect in terms of of support and the need for greater sort of education and awareness, which can contribute to traumatic birth experiences and problems in terms of mental distress after delivery as well.
Thank you. I got another question from this one from Janet Nines, and it reads, in a group, I'm aware of the women use their dancing and singing to discuss their concerns and lift the spirits when flagging in the group. They also wanted to use the cultural practices of dancing and singing to make income, but found some expectations that this could be available for free by community sector and councils. Any comments on this intersection?
Yeah, that's a really great question. And that's something that actually has come up in my work with migrant and refugee communities around music making. And there seems to be two narratives around the role of music. On the one hand, multicultural programs emphasize the importance of music in building strong communities and celebrating identity, and these things that are seen to be really important by communities themselves as well. On the other hand, arts funding emphasizes creativity, musical excellence, and commercialization and income through the arts. And often multicultural artists or artists who are from refugee or migrant background find that they are automatically slotted into that multicultural arts category, and therefore it's a lot harder for them to achieve these high-level opportunities in terms of earning income through their music and dance practices. So that's a strong tension that has come up in my work over the years, and I think it's a problem, and for some participants directly linking to racism and discrimination in terms of pigeonholing artists into certain categories and excluding them from other sorts of opportunities. So yeah, I think that's an important issue. And I think the solution is to provide avenues and spaces for both, right? For the music that sits outside of commercial and sort of arts, that kind of arts funding, and also providing avenues for artists to make money from what they're doing if they want that.
Thank you. Another question for you. Is there any study about hand-pan music in the context of therapy, for examples to be used during breathing relaxation exercises that you're aware of?
Studies on what? Sorry, I missed the first part of that.
Yes, it reads, is there any study about hand-pan music in the context of therapy?
So I'm not sure what that is, but I'd be interested to learn more. There is some interesting work around breastfeeding practices, and in some of our work, particularly in South Africa, the role of song in facilitating breastfeeding came up a lot. And so some of the most popular songs through the co-design process that we facilitated were specifically around my favorite song actually is a song with the words praising the very, very cute, fat, breastfed baby. And they're using this song, singing with mothers who are having trouble with breastfeeding. And it's a way to relax them. So the singing actually creates that kind of sense of bonding with the baby and then enables them to have a much different experience of breastfeeding than they were having before. So some really interesting, quite specific, everyday examples of how music is used, which I think is really fascinating.
Mm-hmm. Yes, and I think this addresses a question that I'm if I interpret the question rightly, is there space to use music to enhance, breathing and relaxation exercises, which we do in lots of our groups.
Yeah, absolutely.
Angela, I might go back to you now. Are you involved or in or aware of any advocacy or best practice at state or Commonwealth level to address the multiple structural barriers that people from refugee backgrounds with disabilities face in terms of accessing in the IS and services. Back to that topic, supports, housing in language and culturally safe supports that refrain them from ableist responses. Are you aware of any advocacy programs that support people from refugee backgrounds with disability to be empowered and autonomous in the context of supporting the safety relationships and disability rights?
Yes, so there's nothing particularly structured that I can think about, but there are lots of advocacy activities that are occurring at local levels. And, you know, I mean, Starts is a good example, but I'm certainly aware of within New South Wales Refugee Health Service of their support group for people with disabilities and carers. And they've set up a group that comes together regularly that involves bicultural workers, and they have a team of on their staff who support people with disability specifically from refugee backgrounds. And so they've developed some expertise around that and helping people navigate systems. So I think there are those things happening, you know, in different pockets. There's no overarching advocacy group. There is a multicultural disability advocacy organisation, but I'm not aware that they're doing anything specifically around people from refugee backgrounds. So there is certainly space for that to be happening. We've, based on our research, you know, we've tried advocating with the NDIA around some of the issues that were raised with us by people. It could have been that it was, you know, it's been in a state of flux, as we know, for some time, but we didn't find them to be particularly receptive to hearing about what the research was saying specifically around the NDIS. We've written journal articles, but we know lots of people don't read those. So, you know, there's certainly avenue for other sorts of advocacy attempts. Yeah.
No, thank you. There's another question also addressed to you, Angela, and it reads, I'm interested about the differences in cultures as to what is a disability. Medical models can be seen as a negative, and work needs to be done to help people understand how our models and system work and why. And of course, it's a very rich question that encompasses a lot.
It does, absolutely, yes. So, you know, our research, we use the Convention on the Rights of Persons with Disabilities definition of disability, which is pretty broad and fits more within the social model than the medical model. And so that's really looking at how individual impairments, and that language is used from the international classification work, really how individuals' impairments intersect with the environment, so barriers within the environment, and that's what creates disability really for people, is about, you know, how that then means that they can't access services, or that services are difficult for people to access. So, you know, all the time there is that line between the medical model, which is around the diagnosis, and as that first question that was raised, you know, that is the criteria for accessing the National Disability Insurance Scheme. But there's also this sort of bigger picture about what it means in terms of people's functioning within their community, and within, you know, the way that communities can respond to people. So I'm not sure that I've really answered the question there, but, you know, that there is, I think we're always going to have those things going hand in hand, but really the focus is not so much for us, that is for other researchers, but the focus for us is not so much around what the person can't do, but around how we can make sure that the systems and services are accessible for people, due to a whole range of, you know, addressing a whole range of barriers.
And for another follow-up question to this, and that suppose if you could comment on the potential differences between, the different disabilities, but particularly what we see more in the context of all the horrific things that are happening in the world at the moment is an enormous increase in acquired
Yes.
disabilities, and particularly I think we've never seen so many pediatric amputations, for example, and what do you think would be the impact of these, and are there differences, and are there differences in the way that we need to work with this?
Yes, yes, absolutely. So I've just spent it came back in July, but I'd spent the previous 7 months on academic study program or sabbatical leave in Europe, where I worked with people in Sweden and Germany and in Turkey. And in Turkey, I was working with a non-government organisation called Hope Revival, which is run by Syrian refugees living in Turkey, and they work with people in northwest Syria. And they were telling me, 37% they estimate of people within that area have disability. And that's, more than double the world average. So that's huge. And much of it has been caused by the war itself. So a large number of people who've had amputations from, explosive devices, and a large number of people, and particularly children, who are deaf due to the explosions and the, very close contact to explosions. And so, these are people who are currently still living in Syria, who are living in as internally displaced people, often in camps. And so the level of support that they're able to provide to people is quite limited. They certainly do their best, and some humanitarian aid gets in, but it's still a very difficult situation. And obviously we're going to see that in Gaza, in Lebanon, and in other parts of the world as well. People that spoke to here as part of our research tended to have more lifelong disability. So we spoke to a lot of people whose son or daughter had intellectual disability, who had acquired brain injury or other things that occurred in childhood, or chronic illness. But certainly I would think that there are a reasonable number of people here who also have disability as a result of their war experiences. And certainly, the overlay of psychosocial disability with people who have trauma is huge as well. Yeah.
Thank you, Angela. And again, something that we will need to keep looking into, as you said. I think certainly we've seen in Gaza. I was in a conference yesterday that when with some information shared about the number of pediatric amputations, as big as we've seen, but we also seen this in a contact with people from Ukraine, in what is coming from Sudan. So it's clearly something that we may need to look further into. Might go back to you, Bonnie. And there's a question from Vina O'Sullivan, who's a stance physiotherapist and an ex-classic dancer. And the question reads, I use dance in a culture-specific way. It is very individualized to my clients to help them get more in touch with their bodies, to help release emotional tension. However, this is a one-on-one decision and process. To have a combined movement and music-based therapy-based workshops for clients would be useful, and to combine traditions, not just clients from the same backgrounds. Can you comment on this and maybe provide some hints about what would be important in bringing dance and marrying that with a very rich array of cultures that we work with?
That's a great question. Thank you. Yeah, absolutely. And in the chime work that we've been doing in the Gambia and South Africa, it's music and dance combined. So the typical session will involve singing, percussion, and dancing, hand clapping, all kind of coming together in a way that's flexible and allows people to participate at their comfort level. So I think I'm sure that the person who posted this question would be very aware of this, but the flexibility is important in enabling participation and really encouraging active engagement, rather than if people feel less comfortable dancing in front of others, having a situation where it is a passive spectator watching, which may have benefits, but not at the same level necessarily as that kind of active engagement. So I think combining music and dance is wonderful, and we do it in a lot of our programs. And that kind of tiered participation and the emphasis on meeting participants where they are is great. In some sessions, what we are doing is a combination of individuals sharing songs and dances from their culture, and then teaching and learning. Right? So it allows that sense of pride and ownership, and let me share in the way that it would be done from my background, and then sort of having that sequential participation, but then also adding on that element of full group participation. So can we all learn this dance together, even if it needs to be a little bit simplified in a way to allow people to actively engage. And that can be really powerful too, in allowing the person who shared the dance or the song to feel recognition and to feel like they are, others are appreciating what they have brought to share. So yeah, I think that's a really important topic, and dance is often overlooked, but it can be really beneficial. And in many of the responses to our Chime program, they reference the music and the dance together, and the feeling of joy that can come from moving your body and the exercise, and along with the singing and connecting with others. So yeah.
Well, there's so many layers, to what music and dance can bring into those sort of group interactions. Are there things, I mean, we usually, screen people from multiple groups that we do to try and ascertain situations for where a particular intervention might not be appropriate. In doing this, is it things that we should look particularly into when we're considering music and dance in our group interventions?
So I think they're generally considered to be very low risk. I think perhaps the most important thing is the individual interest, right? So many people really enjoy music and dance, but not everybody, or people have different levels of comfort, particularly in a group setting. So in our programs, we have run the Chime intervention as a universal intervention, in the sense that we don't screen people for depression and anxiety symptoms. It's open to everyone. And that's for a couple of reasons. One being that it reduces stigma if it's open to everyone. You don't have the perception that this is for people with mental illness per se. The other reason is that there can be benefits in preventing the development of problems, as well as in reducing symptoms for those who are already experiencing them. So we didn't have criteria for inclusion of that sense. We have excluded people who had a history of psychosis in these particular sessions, and that was due to the support services that we had available and the advice of the local health experts.
Thank you, Bonnie. Yes, that's such an interesting topic. I might go back to you now, Angela, and there's a question that reads, can you please comment on shame around disability in refugee communities, and how to support refugees at the individual level as well as the community level to combat this?
Thank you. That's an interesting question too, and that concept of shame has certainly come up in the research that we've done, over the last 7 years. So, people have certainly told us that there is feelings within families that the disability is the fault, if you like, of the mother in particular. And this is something that we've seen within Australian society in the past as well, that sort of blame attached to the mother, but also more broadly, the feeling that the family, that there's some issue with the family when a child with disability has been born into the family. We also have heard from people that there is more shame when the disability is from birth rather than acquired, and particularly if it's been acquired due to war, there's less shame and stigma attached to that, because that's seen as, you know, bad luck, if you like, or something that's happened that's outside of your control. And we also have been told, you know, that there's often more shame attached when there are mental health issues involved, that people feel that's something that must be kept within the family rather than seeking help externally. So certainly they are issues that we have heard about. As I said, they are also issues that are quite universal. So they're things that, you know, most societies have an element of that shame attached to disability, even if they're things that are more historic now than contemporary. They're certainly, you know, still can be there. In terms of approaches to that, one of the things that the co-design group that I talked about wanted to address was this issue of what disability meant for families for people from Syria and Iraq. And one of the videos that we developed was specifically about family and about how disability is talked about within families, and how reaching out to other people is a way of coping with that. I think Starts has got the videos on your website. I hope you do. You were part of developing them, and other organisations do too. But I'm happy to share those links with people as well, because I know New South Wales Refugee Health Service uses it in the groups that I mentioned previously, and they've said that people have responded really positively to this, viewing disability as not something to be ashamed of, that's part of the normal part of human society, that we have, you know, people have all kinds of different you know, manifestations of themselves, and disability is one of those, and that you know, that it's really about how the society can come together to support that person. So if you're interested in that, I would, you know, recommend having a look at this video. This video and the ones on the NDIS are currently being translated into 5 other languages as well as Arabic, and that's through demand. So we're looking, that's happening at the moment, and that's a combination of Foundation House and New South Wales Refugee Health Service are funding those. So they'll be available, and they're the languages of many different refugee communities. So yeah, I think it is about reframing that, and we heard that from people, that when they came to Australia, they could see how disability was viewed differently to where they had come from, and that helped people shift their thinking around that.
Fantastic. We'll certainly add the link when we publish this in our website. And in the meantime, if anybody's got access to that link and wants to put it in the chat, that would be fantastic. I might go back. Actually, no, there's a follow-up. There's a question that is very related to one of the things you mentioned. And it reads, I'm wondering if links between disability and consanguineous marriages has come up in your research. And if so, what the research is saying about the best practice in supporting families in this situation. And we're seeing this more with smaller communities too.
Yes. It came up in the first lot of research we did with Starts, and it was actually raised by service provider, not families or people with disability directly. So one of the service providers that we interviewed spoke about you know, a greater proportion of people with disability from particular communities due to consanguine marriage. So it just came up as a topic, but it's not something that we've particularly explored. It would be, I think, something that would be interesting to explore with those particular groups. But yeah, I can't say any more about it than that, really.
Thank you. Perhaps another area that, yes, but we need to focus a bit more. Bonnie, I might go back to you. There's a question that reads, I'm curious about the role of music within the context of one-on-one counseling with clients. Has there been much research on this, bringing music to that individual counseling situation?
Yeah, so I think a lot of work in music therapy uses a combination of approaches, so talk therapy as well as music making. And I think it is something that can be really effective and tailored to the particular individual. So thinking back to the different examples from the research around individual music listening. So that can provide, in some of the research that I shared, the listening to songs actually provided a way in to feel, to think through, and to cope with difficult experiences. In other cases, music therapists will actively engage, sing, play with a client, which can be sort of very effective but it comes from a place of starting from understanding that individual and their musical background and preferences, and then also often engaging them actively in music making according to their sort of individual abilities and how they want to engage. So it's quite flexible. It can be I think, a really useful tool to incorporate into that kind of one-to-one therapy. I think so. There are specialist skills and training, right, that music therapists bring to those kinds of activities, but because music is such a universal aspect of culture, it is also something that people are always drawing on in their own lives in diverse ways. I mean, not always, but people have music as a part of their unique individual and cultural background. So for that reason, I think sometimes people without specific training in music are reluctant to engage with it, but there's no reason to be reluctant, in the sense that it doesn't necessarily require musical skill to engage effectively with music making or listening with a client.
Can we explore a little bit more that issue of the reluctance? And there's actually a couple of things in the chat that allude to this. I certainly found it in my own practice in a few years ago, bringing tango into groups, and it's what would you suggest that the best ways to address the reluctance? Because certainly my observations is that people, you could see that they were gearing to go, but there was a lot of reluctance. And once they overcame that reluctance, you could see that it also, bringing the music and participating in the dance gave them a lot. But it's usually quite a high threshold for people to cross. Any tips about how we can facilitate this, how we can bring, a bit of a soft entrance into music and dancing groups?
Yeah, I think that's a great question. And this is a question that comes up continually in my work. And because I work across multiple cultural contexts, I'm very aware that there are different norms around music participation. And particularly in Australia, it is much, much harder to get people to engage in music than it is in other contexts where I work, particularly Gambia and South Africa. And this is not because people are inherently less musical. It is because we have culturally specific ideas about musical talent and expertise, and ideas about musical excellence that really do serve to disempower people from their own music making. So my recommendation is that we reframe what the point of music making is, right? So it is not to get the notes perfect. It's not to have a polished, perfectly beautiful performance to put on a stage, although that may come out of it. The point is to engage with other people, to have that feeling of individual expression. And it's not, if we challenge that idea of musical excellence and talent, and then we can recognize, actually, even if you don't have a beautiful voice, you may be the perfect music facilitator because you can make people feel included and welcomed to join in with you. So yeah, I think those, going back to the kind of principles that underpin facilitation of music making, it really is about that, like facilitating others' engagement rather than showing my own expertise.
Thank you, Bonnie. And you then said I was going to have a follow-up question. Is there's also reluctance on our side as you know, in our role as facilitators of you know, in either one-to-one counseling or in, you know, in group facilitation that uses music and dance. So that's a great comment, that we also need to lower the bar, and that might actually be helpful. We're getting to the end of our session today. So I like to throw, I mean, you know, it's wonderful to have, you know, the two of you working on quite different areas, but I'd be interested in you know, have you both together in the panel to maybe use the last few minutes to explore a bit the possible intersections between those two areas. You know, how we can, you know, use music and movement and in different ways to work with people with disabilities to construct spaces where we can address both, you know, stigma, the shame, and get all the benefits, you know, that these interventions can bring.
Absolutely. I mean, I was just going to say I use quite a lot of arts-based methods in my research, and that's, you know, involved things like body mapping, where people have a big body outline drawn on a piece of paper, and then whatever the topic is that you're talking about is represented in drawing and collage and writing on the body map. And people are often similarly reluctant to put the first mark on the body map, because they say, I can't draw, I can't make art, I don't know how to do this. And it's about saying to people, it doesn't matter what it looks like. It's about you expressing your view about it on this, and sometimes just encouraging people to make that first mark, and then they're into it and away. But I haven't used music and dance, but I can see enormous potential for that. And it was so interesting, Bonnie, hearing about your work, and, you know, particularly in that context of mothers, yet new mothers, expectant and new mothers. I mean, I just think that's such a joyful way of exploring what that experience is like for people. Yeah.
Thank you. And Angela and Bonnie, what's your perspective on this and that intersection and the potential for it?
Yeah, I think there's so much connection here. There's a lot of really interesting, really important work on music and disability. And some of it addresses similar themes around stigma, around music as a non-verbal form of communication that for some people may be more accessible. So it may be a way for people to express themselves and connect with others when they find that challenging through verbal communication. So there's a lot of really interesting work on that. And I've also really liked your points, Angela, around arts-based methods. And I'm looking a lot at the moment at music as a methodology, particularly as part of co-design, and how it can challenge some of the power dynamics that we see between participants who may have positions of more prestige and participants who may feel their voice isn't welcome. So through music making, we can sort of shift the dynamics around that, and it becomes a way of exploring and sort of finding areas of commonality and building those connections too.
Absolutely.
Fantastic. Look, thank you so much. It's been, you know, two wonderful presentations, fascinating, you know, in different ways. And, you know, what a wonderful discussion. I think it's been great to hear from you both to get, you know, a better understanding of some of the I suppose the theoretical points and the frameworks that we both shared, but also, you know, so much came out in the discussion, in particular about, you know, how we can bring this into practice and help us improve, you know, the work that we do, you know, with our clients and the communities we work with. Thank you so much.